Perfectly delightful. And yourself?
Good. Beth, does it look like we have folks here? Thanks.
Yes, you're set.
I appreciate it. Sorry, I'm a little late. I had a link problem, but Kayla fixed it. So thank you. Is Phil with us today? Phil on the call? Trustee Hussey?
Nope, I have
No.
not.
Okay,
See.
I just wanted to make him feel comfortable, but he's not here. Okay. Let's call the Human Resource and Labor Relations Committee to order, please. And Beth, if you could take the roll call, I'd appreciate it.
Yes, trustee Flood,
Here.
trustee Riley.
Here.
Trustee Michaud,
Here.
trustee McMahon,
Here.
trustee Loring.
Here.
There you go.
Thank you. Please keep your phones muted like we're always supposed to. I guess we will go into executive session, and I'll say offhand, it looks like we probably are, would you say, Carolyn, half hour to 40 minutes, something like that in executive session, so people know that?
I would say a half hour would be
Half hour.
probably more than, yep.
Okay. Could I have a motion for the committee to go into executive session under the provisions of MRSA section 405(6)(a) to discuss the evaluation of personnel and consideration and discussion of appointments, evaluations, employment, and duties, and one MRSA section 405(6)D to discuss planning for negotiations and communication with AFM, UMSA, AXUM, police, PETFA, and service and maintenance units?
So moved.
Thank you.
Second.
Thank you. Motion made by trustee Michaud, seconded by trustee McMahon. Beth, would you please take a roll call vote?
Yes, trustee Flood,
Yes.
trustee Riley,
Yes.
trustee Michaud,
Yes.
trustee McMahon,
Yes.
trustee Loring.
Yes.
Motion carries. I'll move you into exec session.
Thank you very much. All right, everybody's back. We've concluded an executive session and we're now in the public meeting session of the Human Resource Labor Relations Committee, October 28th, 2024. And the first topic we had was an annual review we do of the Employee Health Plan Task Force. It's a scorecard, and I don't know if Carolyn, you wanted to introduce this person or not, but I will say that the Senior Director of Health and Benefits of the Willis Towers Watson's organization, Denise Stevenson, will be here to talk about that. Carolyn, did you have anything else you wanted to add?
Well, I would just add that I don't see Denise or Jason Talbert, who are both we're supposed to be in the public session, so I'm wondering if we are in the public session.
Yeah, oh, there's Jason.
There we
We're
go.
reaching out to Denise. She should be joining one
Yeah.
moment.
We're a little bit early, so.
She was with us before, so I think
Oh, she was. Okay.
Yeah, she was with us when we went in.
Okay.
Hi, good afternoon, everyone.
Hi.
There. Well, you missed a wonderful introduction, Denise. We just said how, wonderful your work is.
Oh,
I am actually just going to turn it right over to Denise to offer the scorecard. And then I'm sure, as she would say, feel free to ask questions along the way. And then Jason Talbert has joined us, where this is really an area of HR that he specializes in. So he's here to answer questions also, along again with, I'm sure, Amy, Susan, anyone that has information. But Denise, if you would like to start with your report, and then we'll go from there.
Yep. Thank you, everyone. My name is Denise Stevenson. I work for a company called Willis Towers Watson, and I appreciate being a honorary member of the University of Maine system this afternoon. I will say that working with the Employee Health Plan Task Force, it's an absolute professional joy. It gives me the opportunity to connect and hear from various cohort groups across the university, and I really believe that by having this group come together each and every month, that it gives them sort of safe space, and I would say common understanding and a common language. As we all know, I do, health and benefits all day long, and, you sometimes can slip into insurance speak that's not familiar to everyone. And I think by having consistent attendance at these meetings and strong engagement, you increase everyone's understanding and give them common language. So it's truly a joy. I will share my screen. This data is a little old, and usually I am invited to come in and present earlier in the year. So this is calendar year data, and normally it would be ready to present over the summer. I think because of competing agendas, this session got pushed a little later in the year. So I will try to provide commentary on sort of just how things are also trending through 2024. So this is a report on calendar year 2023. I'm going to collapse my window of the attendees, which will make it harder for me to see you all. So please just give a shout at any point with questions. I'm happy to sort of entertain questions along the way. Also, I probably will not be clicking back and forth into notes, so I would prefer just give a shout and rather than typing questions into the group chat, if that's okay with people. Okay. So I know there's some familiar faces here, but for any new faces, this committee, it's called the Employee Health Plan Task Force. And it was originally created way back with the Accountable Care Act. So back in 2010, when the ACA was released, it was very broad, very comprehensive piece of legislation. And at the time, there was a provision called the Cadillac tax. And this committee was brought together as a multi-stakeholder group to try to make sure that, and the term that we use is bend the trend, because we were trying to ensure that our healthcare costs did not get to a point where it would exceed the Cadillac tax. The Cadillac tax ended up being sunset. It's no longer part of the ACA, but the group still is committed to what I want to call coming up with mutually agreeable ways to bend the trend and try to address increasing healthcare costs. We do have members from the executive team, campus leadership, finance, HR. We consistently get attendance from each and every one of the bargaining units. Susan and sometimes some of bargaining leadership also attends. And I would say what we have not had is sort of consistent, folks from non-rep, if you will. Our non-rep folks tend to be, either from the executive team or finance or HR. I think that there has been some discussion about having some just non-rep members join the committee to help round out the discussion. The committee does have an established charter, so we kick off each and every year. So we're just wrapping up 2024 now, but in January we'll kick off a new year, and with a new year we always review the charter and I would say the ground rules, and we revisit what I would say are 4 primary pillars for the focus of the work. And so the agendas do vary each and every year and each and every meeting, but we try to touch upon, in our attempt to bend the trend, we look at things like our network. So we've been partnered with Cigna. We're on a PPO plan. On occasion, we talk about how do we steer people to high-performing providers. And those are considered providers who have higher quality, lower cost, good, positive employee experience. We focus on the plan design, and we want to encourage people to sort of use the plan wisely. And so the group will debate, different features that would drive some positive utilization. Some examples over the years was when our emergency room use was much, much higher than benchmark. We talked about some targeted changes in the emergency room and the urgent care space. We know that there's opportunity to use telehealth. It's a more cost-effective point of delivery. So this group discussed waiving the copay for telehealth in an attempt to encourage that type of utilization. So very thoughtful discussions around plan design. Obviously, the overall health of the population dramatically impacts sort of our claims spend. So we talk about how do we increase awareness and get engagement in wellness programming? Are there certain targeted communications that we should be doing? Do specific cohorts need some additional support? And then obviously with all of this, making sure that there's an effective communication strategy that is right for your different populations. So section 1, it has been a very difficult period for healthcare cost spend. This tracks what I'm going to call per member per month. So it's not per employee per month, it's per member per month, which is like I always say, count the belly buttons. So it includes employees, spouses, and children, the number of members. And if you started healthcare costs back in 2010 and applied national trend and compared it to the University of Maine system trend, you have outperformed national trend. So this yellow line on the chart is just if we had taken your costs way back in 2020 and applied national published trend, what your costs would have been for calendar year 2023. And you can see the purple line is what your costs actually were. You can see the dramatic dip in 2020 due to COVID and the healthcare shutdowns, and then the subsequent resurgence of spend. And then it sort of stabilized in 22, and then took another dramatic spike in 2023. The difference between sort of the purple line, which is your total spend, and the light blue line is with and without high cost claimants. And over the years, what we've seen in the industry, this is not just unique to the University of Maine system, but it is definitely having an impact, is that the sort of the prevalence of high cost claims and the magnitude of the high cost claims is becoming increasingly a greater portion of the spend. You can see the lines are significantly closer 10 years ago than they are today. And a lot of that has to do with sort of specialty oncology drugs. Also, a lot of pharmacy specialty drug spend is also pushing some of that. And then you also have what I'm going to call just some very unique, known, ongoing high cost claimants that will likely be in the risk pool for years to come. Nationally, for 2024, I will tell you this was, again, another very difficult year, not only for the University of Maine system, but for healthcare trends. And I think the most recent white papers that have been published by reputable sources like PwC, they said nationally, healthcare cost trend is in about 8%. Any questions? We do, again, and one of our pillars is the network. And so we do look to see if people are accessing the Cigna network. And, you know, it is difficult. Maine is a rural state with, and the system has employees, you know, in some very remote locations. I would say that the Cigna network has been providing good access across, and you can see, you know, about 97%, if you will, of your claims are all in network. It matches Cigna's norm. We also track to make sure that people are accessing primary care over specialty care. We do tend to structure our copays to encourage, obviously, anything preventive has a zero copay, zero deductible for preventive care, but we do use lower copays for primary care. And your plan designs are actually pretty unique in that the task force decided long ago that things like mental health therapy or physical therapy or speech therapy, things that people would need to access on an ongoing basis, be treated like primary care. And you've saved your specialty care copays for the more expensive specialties, dermatology, cardiology, oncology. So we track to see what percentage of your care is primary care. So you do have more primary care than the norm. These other two metrics on the bottom of this page is something that the task force started to tackle at the over the summer sessions, and will likely go and be something that we spend some time on at the beginning of next year. I would say that for a period of time, what we were trying to do with Cigna Care designated providers, those are like, we call them, if you will, tier 1. And those are specialists that are meeting a metric for high quality and low cost. And it's with some attrition of network and availability in Maine. There's just less providers. And so there's less providers that are meeting that standard. And so we are giving some consideration to perhaps pivoting from that type of an approach to looking at some more newer strategies around sort of centers of excellence. So I know that this is sort of top of mind of things that the group wants to tackle in the new year. And then on the bottom of the page, this CAC aligned statistic has to do with the fact that Cigna negotiates a certain type of contract with hospitals that has some quality metrics embedded into the language, and that becomes a CAC contract, if you will. Every hospital in the state of Maine is on one of those risk sharing contracts. And so what we're doing is measuring the number of providers who are aligned with hospital systems that have that type of contract. And you can see, because many of the physicians in Maine are aligned with a hospital, that your percentages are higher than what Cigna would see nationally.
Denise, can I interrupt? This is Trish. I was struck with the in-network numbers as impressive until I read the New York Times. Cigna uses MultiPlan as a claims adjuster, and I don't expect you to answer this now, but they are assessing plans significant fees to get these results. And I'd like to see a cost-benefit analysis at some point of the Cigna operations.
Yeah, of course. And what I would say to you is that Cigna contracts with their primary network and they're doing that own contracting. They do use MultiPlan as a secondary network when they don't have a direct contract. And then when that type of approach is used, there may be a percentage of savings. So I do know what you're alluding to, and we can get you a report on that.
That'd be great. Thanks.
You're welcome.
Denise, I had a question too on the graph, the primary line graph that you had that showed the national trend and then our trend, I guess. It's nice to see that we were trending lower than the national, but it looked like the graph shows that we're increasing at a faster rate than the national trend when you get out towards 2021 and 22 and 23. Is there some particular reason for that, or do you have any kind of theory about why we're lower, but we're accelerating faster than the national rate of change?
Agreed. And I would say that it is primarily due to pharmacy costs.
Okay.
So if you can see sort of medical, so this sort of washes out a little bit, but we've been talking about this at IFTIF. Your pharmacy claims have been double digit. And even if I did sort of showed you a longitudinal, even if I went back a couple of years,
Yeah.
Your pharmacy spend has been increasing at a double digit rate. And some of that has to do with the fact that you're an older population. So, more complicated healthcare risks and a higher usage of drugs. So your utilization is high, but because the state of Maine, so this is really interesting, the state of Maine has legislation that does not let plan sponsors take advantage of manufacturer coupon savings arrangements. So like Cigna has a relationship or a program called Save On. And all of the carriers have them. Like Aetna has it's called Prudent RX, and another carrier has something called Pillar RX, and Cigna's version of this is called Save On. And you as a plan sponsor have not been able to take advantage of that marketplace opportunity. So most plan sponsors are highly almost mandating that if their population needs a specialty drug and it's part of the program, they must participate in the program. And that helps mitigate the cost of specialty RX. And you are not allowed to have that type of feature. And it pains me a little bit.
Right. Okay.
It's a policy issue about the inflationary impact of those coupons. But who's our PBM? Because that's another area I'd like to explore a little bit more.
Yeah. So right now you've been carved in with Cigna, so you're using Express Scripts. I will tell you that we are scheduled to go out to competitive bid for both medical and pharmacy, and that work is starting in December of this year. And so we expect to be, we're establishing who's on the selection subcommittee. It'll go through a formal procurement process. There's a formal scoring methodology, and all of that work will be happening between, I would say, December of this year and in April of next year. So we're looking to competitively bid both medical and pharmacy, and we'll likely look to, some creative, non-traditional approaches in both spaces.
And I assume some of the issues are what we demand of the PBM in the bid, right?
Yes. Yep. But we do have to live within the confines of your legislative landscape. Okay. And did I answer that fully? Are you good?
Yeah, I'll look forward to seeing that bid.
Okay. Okay, so network management, again, and as part of the bid process, right, we're going to be looking for cutting edge solutions in this space. Both, how do you steer people, right, to high performing providers and do it in such a way that it's a positive member experience and that it's got good outcome and that you are truly utilizing providers who have documented best outcomes. Plan management, again, a lot of these statistics are just some key, like, is the plan performing well? Are there actionable things, right, that we can help educate folks on? So I talked a little bit about emergency room visits. Again, if I had gone back further in time when we sort of started this work, your emergency room visits were quite high compared to the norm. And the group has done a good job educating the memberships to, stay out of the emergency room. And I actually think the pandemic helped us a little bit with that because nobody wanted to go to the emergency room. But we are seeing sort of those visits creep back up. And in discussing this with IFTIF Friday, actually, we talked a little bit like, should we do a drill down? Should we better understand what's happening? Is this a capacity issue? Are some of the options closing? Are people not utilizing telemedicine? Like, you can see we've had a little bit of an uptick, but this is a dramatically underused benefit. And again, we have said it, all the units have agreed, right? Let's put a zero copay. Let's make sure that there's no financial barriers to using this type of service. So just trying to get some momentum there. Your generic prescribing has always been best in class. And again, we structure the copays to encourage people to use generics. And you also have very strong Retail 90 program, which is actually also a function of legislation that basically says that if there's a retail pharmacy that can match mail order pricing, we treat them like a mail order network and get the benefit of that. So very strong Retail 90, if I will, right? It's more cost effective to buy ongoing drugs in larger supplies rather than every 30 days. And then the last metric has been the use of the EAP has just really not, there's so much need for mental health and substance abuse services. And we have not been able to get good engagement within Cigna's EAP program. And the member experience had not been as strong as we would have liked it to have been. And so one of our projects for this past year was to go out to competitive bid for an RFP, and ComPsych won the business. It was a very exhaustive process. And again, we always ask members of IFTIF to participate in these bid selection subcommittees. So again, we're getting input from the various cohort groups, and the group selected ComPsych for 1/1/2025, and feeling very good about launching and supporting a new program. So we're hopeful that we'll see a dramatic increase in people's willingness to engage in the EAP. And one of the requirements that the group was very focused on was that they wanted it to be a concierge model, so that when someone called and needed help, that they weren't just given a list of providers and then they would have to like dial for donuts and see who was taking new patients and who had availability. The expectation is that when someone calls the EAP for help, when they call ComPsych, that they will help them identify, a relevant, culturally appropriate, convenient clinician who is taking new patients, and that they will help them actually book that appointment. So there's a higher expectation for what good service means. We really do want people to have a positive experience, and the EAP pricing is actually a slight hair better than it was. So it's expected to be a win on many fronts. Any questions there?
Trustee Flood, can I ask a question about that?
Yes.
Please do, please do.
ComPsych, is that a resource available for students, or is this just faculty and staff we're talking about here?
At this moment, we manage the faculty and staff programs. I don't know if you have a student resource available.
We did. It just expired after a long period of very low adoption, very low usage, which is why I asked. So we're looking at student telehealth resources right now, and wanted to make sure that I wasn't duplicating efforts. Thank you.
The next section has to do with wellness, well-being. This is actually something that is in the process of being sort of a blue sky workshop. So we're going to kick this off in November, again with a subcommittee of IFTIF. And the current wellness program, the way it's structured is you sort of have level 1 activities, and if people participate in level 1, they earn a premium differential. And there is some legislation outstanding on a federal level that is sort of pushing this group into having to thinking about restructuring how level 1 is handled. Right now, about 90% of the folks who are on the medical plan do indeed complete a level 1 activity and pay what we call the P rate. It's a lower rate for their health plan contributions. If people choose not to participate in level 1, they can still have medical coverage. They're just paying the non-penalty rate. They pay the N rate. This is being put on the table for just some blue sky discussion. Also, there's something called level 2, which more is sort of wellness activities at the campus level. There's activities on sort of the Cigna platform. And if people complete level 2, there's sort of $100 award, if you will. They can earn it. Their spouse or domestic partner can earn it. And there's, less people who sort of participate in that type of activity, but about a third of the folks do. And then this last line, are you engaged with a health coach? So in order to earn your level 1 incentive, you either have to have a preventive care appointment, or you have to have a coaching session with a health coach. And then we look to see how many folks are using that health coach opportunity. And that has started to sort of erode over time. So I think this just needs, legislatively, it might need a refresh, but I think we've been doing this now for many years. And I think the group is open to discussions around what a more modern approach might look like. Cigna is in the process of also revamping their engagement platform. So that is negotiated as part of, like, when we go out to bid, we make the medical plan vendors provide us with a platform to measure all of this, and they are not allowed to charge us for this. We also ask the bidders for wellness dollars to help support the wellness effort. So the wellness program, we're going to do some pre-design work at the committee level. It will ultimately end up as part of the formal bid specifications that will be launched later in the season. The next item has to do with communications. We do spend many many hours within IFTIF talking about how to increase awareness, how to make sure we're touching folks who might not have access to computers. We press our vendor partners to do outreach as well. And so this is just an example of sort of some of the wellness materials, you know, Reach Level 1, Reach Level 2. Obviously, the launch of the new EAP program, we'll spend a lot of time talking about how to increase engagement and awareness as part of our engagement discussion. The next section is section 5, health improvement. So we're measuring, you know, are people getting their preventive care? Obviously, 2021, the system was very slow, right? This is post-pandemic. It was really hard to get people to re-engage in the healthcare delivery system. And there was a huge backfill of people. So it sort of took some time to get usage up to pre-pandemic levels. You're currently, you know, doing some good work. If you compare yourselves to sort of Cigna's norm, you're far surpassing Cigna's norms. And then what was interesting is your screenings, actually, even straight through the pandemic, they never dipped. Your members are very good at taking care of themselves. So things like mammograms, I think this number is held. You know, I could go back, you know, 3 years, 5 years. All of these statistics have been very strong. Your population does take good care of itself. Gaps in care measures, like if you have a chronic condition, are you doing what I want to call clinical best practice? So like a diabetic, are you getting your eyes checked? Are you getting your feet checked? Are you taking your insulin consistently? And if you miss something, that's like a gap in care. We don't want those. So Cigna does have algorithms to identify folks who may have a gap in care, and they outreach to them to help them close that gap in care. The goal is obviously to keep folks with chronic conditions well managed so that you don't have a miss or an acute episode. So consistently, your population is very compliant with closing their gaps in care or not having them in the first place. And then medication adherence, again, you know, drugs, specifically drugs that help people maintain stable conditions. We want people to be adherent to their drug regimens, and your population consistently has done that. And then overall, there is an algorithm, WTW, we have a data warehouse, all de-identified information, but we are looking for patterns like demographics, the way people use plans, people's, like, for example, if someone has many emergency room visits, or so it's looking at a combination. There's algorithms of who the people are and how they are using the plan. And so we're looking at average age, and it's nice. We're getting younger. I was like, I'll be a third of a year younger, but age is the greatest predictor of health plan risks and health plan costs. So you've been very stable over the last 3 years, even getting a tad younger. And we are measuring your overall risk score. Again, your population is older, so your risk score is going to be naturally higher. It's going to be above 1. 1 is sort of the average. And then we stratify folks as to, are they very low? Are they a medium risk or high risk? And you can see we've had, with sort of the improvement in the age and the improvement in the overall risk score, I would say modest migration from sort of these very high and high bands into sort of the medium and low strata. So, you know, it's a step in the right direction. 2024, and that's sort of my presentation. 2024 was very difficult. Average spend right now is about $8.5 million a month. It has remained, I would say, stable, but consistently high. I do not see it reversing. I don't think that we're on a bubble that is about to sort of, I think that as in general inflation puts pressure on healthcare systems, they're going to look to recoup those monies. And I think the combination of general inflation, people's mental health, and this onslaught of specialty drugs, I think it's going to continue and it's going to challenge us. And we're just going to really need to continue to be collaborative with this group and, think creatively. But they're engaged. They bring good questions and they challenge me each and every month. Susan can attest to that. She sits through all of the sessions.
Thank you, Denise. Thank you again for the data and the facts that we're a slightly older population of people that comes through loud and clear, not only in this data, but in all kinds of things that we deal with in Maine. But I appreciate you putting this in a format that makes it very understandable.
You're very welcome. And one of the questions that was asked last year, and I just want to say it, is that we do not charge. Our time for this committee is our gift to you. We just see this as so important to the work that you're doing. I just want to say thank you and appreciate being part of this.
Thank you very much. Amy or Carolyn, Susan, any other comments from the people that work with this stuff regularly? Ryan? Good. All right. Thank you. And thank you, Trish, for the questions. And I'm sure we'll get those answered. And I think we're ready to move on, Carolyn, to the next topic.
All right. Goodbye, everyone. Thank you.
Thank you, Denise.
Happy holidays. Okay.
Thank you. Carolyn, I can't see you on my screen, but you were going to give a labor relations update.
Well, I was giving a wonderful update and then I realized I was muted. So
right.
I don't think he hears me. And then I realized, apologize for that. So yes, just a very brief labor relations update. As you're aware, we are currently bargaining with 4 of our bargaining units, AFM, UMSA, and AFM again is our full-time faculty unit. UMSA is our professional salaried unit. AXM, our classified or hourly staff, and our graduate student workers UAW group. So I'm very pleased to say that we have a tentative agreement with UMSA, the professional salaried group, that we'll be bringing forward to you all at the November board meeting for approval. And we are very close with one of our other bargaining units at coming to an agreement as well. And there are a handful at least of bargaining units, bargaining meetings scheduled over the next month. So the discussions are continuing on and moving forward with some elements being resolved at each meeting. So I'm very pleased with the progress that the group is making. And I'd like to thank Amy Parker and Susan Cameron, who are on this call, for all of their work around these very important bargaining sessions. I would also like to just note that, as you recall, we had separated out from our previous bargaining with AFM. We had separated out our distance education proposals. We have moved through mediation and fact-finding on our distance education proposal, and we are now scheduled to participate in arbitration with AFM, and that is scheduled for late January. So those discussions are continuing as well. That really is the basic update that I have for you now, and there will be obviously more to discuss in November at the board meeting with the tentative agreements that we'll be able to bring forward at that time.
Sure. Well, thank you. And again, thank you, Amy and Susan and yourself and all the other people who have been working on this, but also an appreciation, I guess, to the leaders of the organizations that you're working with, because it takes 2 groups to get to a yes. And so it's nice to see those things developing. So thank you very much. Any other questions, folks? We'll move then to a brief discussion on our work plan. And I think I'd go with you again, Carolyn. That's okay.
Yes. And
Yeah.
again, just another brief update. I know that all of the other committees are pulling together their work plans, submitting them to Beth so that they're housed in the board office. we completed our work plan, had it prepared. It is part of your materials this month. But what I did realize in the last couple of days, there were a few very small tweaks, one based just on the presentation that we just had from Denise. She mentioned that typically it's better if her particular presentation is done earlier in the year. So we had it scheduled for October on our work plan. So I'm going to go in and adjust that, move something around to see that that can be a bit earlier, perhaps late spring. And then I have a few other very small wording changes to make, but what you had in the packet today is generally what it is that we plan to submit. One thing that I would like to say, really the changes that we made aside from sort of assigning things to particular months, I tried to look at the other work plans from the other committees and find a format that was similar to theirs. So in the meantime, I've talked to Beth, and I think that what we will likely do is look to try and have a little bit more of a unified template that we can put these work plans into, so that they all do sort of flow and appear to have similar information structured in a way that people would be more familiar with where and how to go find things in the work plan. So something we can think about in a future year. But aside from making 2 or 3 very minor changes to what you see before you, we'll go ahead and submit that to Beth for storage in the board office.
That sounds good. I don't see any hands raised. I just wanted to say that we don't have anything particularly scheduled for our December meeting. We'll work on that in the meantime. There'll be topics to bring forward then. November, we of course don't have a meeting. We have a Board of Trustees meeting, and in August, we had talked amongst ourselves in the preparation for this meeting, and I shared with Chair Riley that we should be able to maybe not have that meeting in August, but again, if we have to reschedule the work that we just had from Denise to August, we can always do that. But right now, we have an August vacation, I guess, scheduled for meetings, so I just wanted to make sure everybody was aware of that, and if you had any concerns to raise those. Is there any other work for the good of the committee today?
That is it for this meeting.
That is it. All right. Thank you very much, everyone. We'll see quite a few folks in November up at the University of Maine in Orono. And I want to thank everybody for a good meeting. Thanks very much.
Thank you.
Thank you.
Bye.
Bye-bye.